So STELLAR-02 was a clinical, the expansion cohort was assessing the combination of zanzalintinib with immune checkpoint inhibitors, the combination of nivolumab and relatlimab inhibitor in patients with advanced first-line treatment ccRCC. So those patients usually would get an immune checkpoint inhibitor, a PD-1 immune checkpoint inhibitor, plus a VEGF TKI. Those are what's currently FDA approved. So the trial had a couple of rationale behind it in each arm. So we had two arms, one arm for the doublet and an arm for the triplet therapy. So in the doublet arm, the thought process was zanzalintinib is a new VEGF TKI with multiple targets that are novel and has a short half-life. So it helps a lot with the management of these TKI-related side effects. For the triplet arm, the addition of the LAG-3 inhibitor is the rationale behind that is that it's been FDA approved for melanoma. And in addition to that, there is some preclinical signs that LAG-3 is highly expressed on exhausted T cells in the immune microenvironment of kidney cancer. So the thought of having two immune checkpoint inhibitors plus a TKI, the hope there was that we could extend the overall survival tail of the curve and have more patient cured or more patient achieve long, durable, deep responses. Yeah, so that was very exciting because we had, as you said, 75% of our patients were in the intermediate and poor risk, with a lot of them were had sarcomatoid features, especially in the doublet arm. So those results that you're citing are from the doublet arm, where now we know that we have an objective response rate of 65%. And in that, we had 8% complete responders, and that's still early on. And these responses, in addition to being deep, they were durable. So 95% of patients on the doublet achieved at least some tumor shrinkage. And we can see that these responses, on average, more than 3/4 of them lasted more than a year so far. And a lot of the patients, like 15 out of the 20 patients that we had on that arm, are still on therapy as of today. Yeah, so the adverse effects of this trial were very in line with what we would expect with an immune therapy plus a TKI combination. Hypertension is one of the very common TKI-related toxicities. We did not see any unusually elevated numbers of hypertension. The way I advise my patient is we try to get like a week of blood pressure log even before starting. I tell all my patients the blood pressure will go up. So we try to optimize that even before we start, having a blood pressure of around 12/70 in all of our patients, if possible, by adding blood pressure medications. And then when they go on it, we monitor for the first week a couple of times and add blood pressure medication as needed. So it's close monitoring and working with the patients and having them change some of their diet habits, less salt and less eating out if possible. So this was a phase 1 expansion cohort. So we showed promising clinical activity with an objective response rate of 65% and a disease control rate of 90% and a durable response rate. The 12-month durable response rate were in the range of 74%. Showed good safety, good tolerability. So currently we have ongoing phase 3 clinical trials in non-clear cell using the combination of Zanza plus immune checkpoint inhibitor. The trial is named STELLAR-304. The lead investigator on it is Dr. Montipal. Hopefully they will finish accruals soon, and hopefully that could change the practice of frontline non-clear cell RCC. In addition to non-clear cell RCC and RCC, STELLAR-02 had multiple expansion arms that were still currently looking at the results. So we had a bladder cohort, we had a colorectal cohort, we had a non-clear cell cohort, we had a second line Zanza in clear cell RCC cohort as well. So these will probably help us assess where Zanza in combination with immune checkpoint inhibitor will be going beyond what is currently open in solid tumors in phase 2 or phase 3 trials?